coordinator of the Chest Pain Center for Billings Clinic. And I'm going to introduce our speaker to you today. And I just want to talk to you for a few minutes about the Chest Pain Center. You know, when we talk about the fact that heart disease is the leading cause of death in the United States for both men and women, we know that that's a little bit overwhelming. And recognizing a heart attack, of course, is not easy. There are a number of risk factors that can't be changed, such as age, sex, and heredity or family history. Now, a number of those risk factors can be changed, and we're going to hear quite a bit about that today from Dr. Kristin Scott-Tillery. And so being a part of Billings area, the region, and knowing that we are an accredited chest pain center, we're actually the only accredited chest pain center in a 3-state region, so Wyoming, Montana, or North Dakota. That just means that we consistently practice the use of evidence-based medicine and publish guidelines to set best practice for treating our patients that arrive here at Billings Clinic with heart disease. It also means that we like to reach out into the community and teach patients about early heart attack care, how to reduce their risk for heart disease, and promote healthy lifestyles here in our area. So today we'd like to share some great information with you. And our speaker today graduated from medical school at the University of Texas Health Science Center. She did her residency at Brown University Medical School, her cardiology fellowship at the Washington University School of Medicine, and also an imaging fellowship at the Washington University School of Medicine. She has special interests in women's health, in preventative care, and also in assuring care for the underserved communities. So she is a great addition to our program. Dr. Kristin Scott-Tillery joined our program in 2011. She's board certified in both internal medicine and in cardiology. So please welcome her here today with us. Thank you for joining us.
Thank you, Susan, for that lovely introduction. So I'm going to talk with you guys today about some stuff that you know really well, but hopefully some stuff that you don't. At any time, if you guys have questions, I'm wide open to answer them. But this is such an important topic for us because this is what we see. I mean, as cardiologists, clearly I see this every day. But, you know, as we age, we see it in our families, in our friends, and we need to be able to recognize it if it's happening to us, but also if it's happening to someone else that we know, and also to reduce risks. So what I'm going to talk about, a lot of these things I'm going to say them 4 or 5 times because those are the really important parts about risk factors and things like that. So what I'm going to talk about first is what we know from the past, our history of our knowledge of heart attacks. Then I'll talk a little bit about where we are today. We'll talk about who's at risk, risk factors, how we treat, and how we prevent. And then we'll have time for questions at the end. Okay? All right. So this is a drawing by Frank Netter. And Frank Netter is one of the premier anatomists of our lifetimes. This was done in about 1934. And he was the one who did all the drawings of the anatomy of everything that medical students have used and still use to this day when we're in the anatomy labs. And what he recognized back then was that this is the face of a heart attack in 1934. And most of y'all recognize this image quite well, right? And so when most people think that they're having a heart attack, that's what they envision. Clutching your chest, taking you to the floor. And that is true. That is definitely a heart attack. But this is only part of the picture. There's a whole lot more to this. So just some interesting points in history because the heart is a really complicated organ. And it really wasn't understood very well until really our lifetimes. Back in the early days, Leonardo da Vinci was actually one of the ones who first kind of got this notion that there was something to do with arteries that fed the heart and gave the heart blood. So that was a long time ago, but we didn't know much about it. Way back here in the 1600s, we thought, well, maybe blood is feeding the heart, even though the heart is what's feeding everything else. Maybe the heart needs to be fed with blood too. Back around that same time, or a little bit later, we figured out that, oh, well, maybe if there's not enough blood, there's a problem there. And then William Osler, who is the most famous cardiologist that has ever lived, and he is our grandfather for everything that we pretty much know now, he was the one who figured out what angina was. And that angina, or chest pain, is only a warning sign of what's going on. That's not the whole picture. And that kind of spurred us to look further into what was going on with this. Okay. The first naming of the word heart attack in the early 1930s, which is right around when Osler drew that picture. I'm sorry, when Netter drew that picture. Okay, so some of the other things that are just interesting. The first heart catheterization, and I'll talk a little about that in a second, is where you actually can go in and look at the heart directly, measure the heart directly by going through the arteries. And in this case, it was the right heart, and look, that's going through the veins, and that was 1929. And I'm going to tell you something interesting about this in just a second. The first people to look at the arteries, the left heart catheterization, was in the 1940s. So this is very recent in our lifetimes. And you want to know how they did it? This is going to freak you out. So they actually did it on themselves, okay? They took needles and put them in their own arteries and traced it up to their own hearts to try to figure out how this all worked. So I'm glad I wasn't a medical student back then. Okay, and so this cardiac catheterization after the 1940s was in its infancy, and it took about 30 years for us to figure out what to do with it. And it was kind of neat that we knew what was in there, but we didn't really know what to do with it. Oh, and here's a nice picture of him cathing himself. Kind of creepy. Okay. The first time we did something useful with this technology was in 1977, where we actually went in and saw a clogged artery and used a balloon to open that clogged artery. So that's 1977. We didn't put a first stent in until 1986. And I don't know how many people in this room have stents. I'm not going to ask for a show of hands, but I'm sure that there's at least a couple of you guys in here. 1986. That's pretty impressive. The first bypass surgery was in 1960, and although bypass surgery is amazing and wonderful and it has an excellent longevity, how many in this room would rather have their chest cracked or would rather have a stent put in? Yeah, and most people would rather have a stent. So, and this is an important thing too. It's kind of an interesting point here, but I'm going to make a more serious point about it. So in 2009, technology was coming around. We had a lot of imaging techniques, CT scans and MRIs, and a lot of these old mummies were taken out and run through the machines. And I'm sure you've seen a lot of different things that have come out on it. But one of the more interesting things is that these patients already, well, they weren't patients then, these folks already had coronary disease. They already had hardening of the arteries and plaque in their arteries. Now think about this. How long did people live back then? Not very long. So these are young people back then. And they didn't have McDonald's. Okay, so these were people that were subsisting and living on the land and probably eating a lot better than we are, and certainly more active than we are today. And they had this that young. Okay, so now let's get to some of the more sobering facts that we need to talk about. 600,000 people die of heart disease every year. Now, when I talk about heart disease, this needs to be broken down. There are several things that fit into this category. One of them is heart attack. Heart attack is also called myocardial infarction. That's the medical term for it, so in case you hear that, you'll know it's the same thing, heart attack. Another portion of this 600,000 people is congestive heart failure, or folks who can't handle their body fluids anymore because their heart is too weak, and we'll talk a little bit about that. And another portion of this is arrhythmias, or people that have funny heart rhythms. So that's a big umbrella, but that's 1 out of every 4 deaths. That is a lot of people. This is a huge field, and it's very important that we get the word out. And I'm going to ask for a show of hands. How many people before I started knew that coronary disease or heart disease was the #1 killer of men? Okay. How many people knew it was the #1 killer of women? Not as many hands. We tend to think of this as a man's disease and as an old man's disease, and it is just not the case. Okay? Yeah. It's more in men than women, but it is the equally first #1 killer in both. All right. Now, I think that's very important. These are some more facts about numbers, and I think that's important, but I think what's more important here is to also realize what this means to our fiscal situation. I mean, this is not an inexpensive disease either. This is $109 billion a year that we spend on heart attacks and coronary disease, and that's a lot. So it behooves us in many ways to make sure that we do a better job at prevention. So this is interesting. So this is talking about why we send folks to the cath lab, but I want to take you back in time a little bit, and some of y'all will remember this. So before we had stents and before we had bypass, how did we treat patients that had a heart attack? And some of y'all might remember this. Bed rest. Long periods of bed rest. So you would come into the hospital, you would have a heart attack, they would park you in a bed for 2 weeks, a month, and let your heart recover. We don't do that anymore. And some of you may know this, that if you come in now with a heart attack, we take you to the cath lab, which is the cardiac catheterization laboratory, find your blockage, put in a stent, you go to the floor, you're home in 2.5 days, going on with your life. So it's a really big advance. And these are some of the reasons we go to the cath lab, but what we're most worried about here is myocardial infarction, and that's what we're going to talk about today. So cardiac catheterization, for those of you who have never seen it or experienced it, I'm going to just walk you through what it is so you know what we're talking about. And these days, we've really advanced because now we can do this through your arm. Usually, we go through your leg. I'm sorry?
Because it's bigger?
Because it's bigger. Mm-hmm. The leg is bigger, and it's easier to get to, honestly. It's easier to access. So what we do is we put you on the table, numb an area either in your groin or in your wrist. And then we take a catheter that's about as long as a pencil, but much, much narrower, very skinny. We put it into the artery, either the femoral artery in the leg or the radial artery in the arm. Okay? Then we take long spaghetti straws. They're about this long. And we feed it through that catheter and take it up around to the top of the heart. And then we put dye into the arteries that feed the heart. Okay? There are 3 main arteries, and I'll show you some pictures. There's the left anterior descending that goes down the front of the heart, the left circumflex that comes down and wraps around the side, and then the right coronary, which goes down the back and feeds the bottom of the heart. We know what it's supposed to look like, so anywhere dye does not go, we know that's blocked, okay? And that's where we go in and fix. And so this is what we do. This is called angioplasty, and there's a little bit of difference in the terms, so I like to bring them up. Some of our older folks will recognize angioplasty before they recognize going to the cath lab or having a stent, because this was the first thing that we learned how to do. And this is when you go into the artery that's blocked. So you can see this is where it's blocked. And then we find that blockage and we pass a balloon. Right here is an uninflated balloon. We get it right where the blockage is, and as you can see here, we blow that balloon up. And what it does is it smashes the blockage against the wall. And you can imagine how nervous you must have been to be one of the first people to do this, right? How much air do you put in that balloon before you get in trouble, right? But we've really gotten it down now, and we know a lot about this. We have many different types of balloons. And the next thing that we do is put a stent in. So after we've taken the balloon and blown the blockage up against the walls, we deploy a stent, which is basically a little metal cage. And what that does is it just holds that against the walls. Okay? And with any luck, you never have worry with that again in your whole life, and you go on and live your life. Okay. All right, so we're here to talk about a heart attack. Now, what a heart attack is when heart muscles die. So heart muscles, like every other kind of muscle or cell, require oxygen. Blood is what carries oxygen. Oxygen's carried in the blood, in the arteries that surround the heart. If there's an interruption in that blood flow for any reason, that causes a heart attack. A heart attack is dead muscle cells. Okay? All right. Here is an example of some images that we got in the cath lab. This is the left heart system here. So this is your left main artery here. And these are the branches that come off. There's the left anterior descending, the circumflex, and all the other branches. And as you can see, this doesn't look quite normal here. Right? So this is a blockage. Okay? And this blockage is causing someone to be losing muscle cells. So the cells, muscle cells that are in the area fed by this are dying. So this is a heart attack. Okay? This is what it looks like after the stent has been put in. Okay? So it's wide open now, and the blood flows freely. And any cells that were hanging on, they're now getting blood, and they're not going to die. So you can understand, looking at this, why it's important that you come in early. Early. Time is muscle. If you're having a heart attack, come in early. We can save more of your heart that way. This is a figure that has gotten much better over the years. Right now, only 15% of people that have a heart attack die from it. Back in the day, it was quite fatal. But now that we have such better techniques, we definitely are doing better with this. There is a certain number of folks, and a certain number of these just fall here, but not all of these folks never make it to the hospital. These are the folks that have the heart attack, drop, and that's it. Either no one's there to call and help them get an ambulance, or the ambulance is too late. Maybe there's no one in the family that knows how to do CPR, these kinds of things. All right? But this number is way better than it used to be. Okay? Risks, again, I'm going to say this about 17 times. Okay? High blood pressure, high cholesterol, smoking, prior heart attack, having diabetes increase your chances.
But you're talking about untreated high blood pressure, untreated high blood cholesterol.
We'll get there.
Oh, okay.
Okay? All right. So this is an EKG. Okay? This is a 37-year-old male. Okay? I want to say that again. This is a 37-year-old male. Came into the emergency room with crushing substernal chest pain like the gentleman in the picture. Right? This right here is how we can tell what's going on. I'm not going to give you a whole EKG course. I'm just kind of hit the high points here. So this right here, you see how this is up, and this is down? That's a heart attack. That's an acute heart attack. And we know how to see that on the EKG. The paramedics in the field know how to see that on the EKG. Another reason why it's important that you get help early and you call an ambulance. Don't drive yourself. This is done in the ambulance. Otherwise, you're just driving, waiting. Okay? So again, signs of a heart attack we're going to talk about. You're going to call 911. You are not going to drive yourself. Okay. The first 2 hours are our danger period. Within the first 2 hours is irreversible damage. You want to be as early as possible. We are incredibly strict about how many minutes it takes us to get a patient from first presentation to the emergency facility, so EMS, to the cath lab with the balloon opening the blockage. Less than 90 minutes. If we're not less than 90 minutes, we have failed as an institution, and we don't do that. So you call EMS, we'll have you in the cath lab, and that blockage will be opened within 90 minutes. So some of the things that I hear as a cardiologist are pretty much heard by all cardiologists, and the American Heart Association has grouped these for us. So these are their common misconceptions. I'm too young. I don't have to worry about that. I'll wait till I'm old. It's an old man's disease. Well, I showed you an EKG that's a real live EKG from a real live 37-year-old man. Okay? I have a 35-year-old nurse that I treated when she had her heart attack. And I have a 40-year-old gentleman as well, the healthiest specimen I have ever seen, who came in with an acute heart attack. So this is not an old person's disease. So those of you here that have children and grandchildren, this is something that you want to keep on your brain as well, and I'm going to show you a case that's going to really drive that home. So we know that the same way I talked about those mummies having heart disease when they're young, we know that it starts at a very young age, and by the time you're a teenager, you have evidence of atherosclerosis in your body, or plaque and hardening of the arteries. I mean, really early. We've done a lot of autopsy studies through the years, looking at specimens, and found the same to be true. I mean, it's quite early. It's getting earlier. And the reason why it's getting earlier is because of this, the rise in obesity and type 2 diabetes, especially among children. This is really a problem, and it's driving these heart attack ages to younger and younger. The second misconception, oh, I don't have high blood pressure because I feel fine. The thing about high blood pressure is you don't feel it unless you're in trouble. So you can run around with high blood pressures for years and years and years and years and never know. That's why they call it the silent killer. However, sometimes it becomes an emergency, and when your blood pressure is so out of control, or has been for a long period of time, then you can have things like a stroke, where a blood vessel breaks in your brain because it's under too high pressure, and catastrophe happens. You can also have the main artery, the aorta, that goes from the heart and feeds your whole body, burst from too much pressure, and that's almost universally fatal. So these are things that are important, and most people don't think that they're in trouble because they don't feel it. Blood pressure goals. Normal blood pressure is 120/80 or less. Okay, that's normal. We'll let you skirt between 121 and 139. We'll kind of let that go before I start giving you medicines. But once you hit 140 or a diastolic of 90, it's time to treat that and keep your risk down. And so that's why we get kind of nutty about treating people's blood pressure, because we know how the benefit of getting it down back into this normal range. This is very important as well. You know, oh, this can't be a heart attack. I think I've got indigestion. Oh, this indigestion's terrible. God, every time I climb the stairs, I get this indigestion. I don't know what it is, but it can't be my heart. So not everyone experiences classic chest pain. There are several other things that people have, and I have treated more heart attacks that people sat on at home for a day, sometimes 36 hours, thinking it was heartburn. They've taken 5 bottles of Tums and it hasn't gotten any better. Okay, so this is something to keep in mind. A third of all people who experience heart attack don't have chest pain, or at least not typical chest pain. Some of the other things that you experience are shortness of breath. That's weird, that you just think, golly, I'm sitting here making a sandwich. Why am I so out of breath? Okay, that's one thing. Another is excessive sweating. Man, I go up 3 flights of stairs and I'm usually fine. Now I go up 6 stairs and I'm pouring sweat. That's unusual. That's another sign of a heart attack. Another is nausea and vomiting. Boy, I go up six stairs and I am so nauseated I just don't know what to do. Strange, though, I don't get nauseated any other time. Or, boy, if I have to climb that hill to get to the mailbox, by the time I get to the top, I'm so nauseated. But if I stop and rest for 5 minutes, it's gone. Okay? These are your classic signs, and we'll talk about them in a little bit. Another problem, diabetes, I'm good. I watch my sugars, I try to stay away from the cakes, I'm fine. That doesn't make me at any higher risk than anybody else. Not true. Diabetes by itself, we call that a coronary disease equivalent. So if you have diabetes, we assume that you have at least some amount of coronary disease or blockages in your arteries just from having diabetes. And what we know about this is that sugar or glucose by itself is toxic to the arteries. Toxic to the arteries in the heart, more so than the other arteries, but definitely all the way around. So it's very important you keep your sugars under control, but even just having diabetes puts you at higher risk. Okay. Well, and I can't tell you the number of times I've heard this. Well, it's in my family. There's nothing I can do about it, so I don't care what my cholesterol is, and I don't care what I'm not going to exercise. I'm going to die of heart disease anyway. That's not true. There are things that we can do to help you lessen your risk and do better. All right? We're going to talk about this so many times, I'm not going to say it now because you're going to know it. You're going to walk out of here being able to tell me all these things. And don't get me wrong, there are genetic things that we can't do anything about. And people are at higher risk from certain cholesterol situations. Familial hyperlipidemia, which is a fancy way of saying high blood pressure or high cholesterol that runs in the family. That's really out of control. Okay. But we have a plan for that. Okay? I don't need to worry about my cholesterol till I'm in my middle ages. And that's not true either. We know atherosclerosis starts early, in our early teens. So why shouldn't we be trying to get it under control early as well? And that's very, very true, especially if you have it in your family. And I'm telling you that I have seen 20-year-olds with heart attacks. The 20-year-olds I've seen with heart attacks had familial situations. And when you ask them, tell me about your family history, oh, no one in my family lives over 35. Okay, that's a big risk factor. Okay, so we check early, especially early if it's familial. Keep your cholesterol low, healthy diet, regular exercise, and medications. Okay. This is what I talked about in the beginning. Heart failure means that we're done. The heart has failed, it's quit working. Okay, and that's not true. Okay, cardiac arrest is when the heart stops beating. Heart failure is basically the common pathway after a heart attack. Damage to the heart, heart doesn't function well. You get to the point where your body can't handle the blood and the liquids in your body, and then you swell and have heart failure. You get things like you can't do anything because if you start to try to walk, you get so short of breath, your legs get swollen, your belly swells, you have fluid in your lungs. And this is what we're trying to avoid, okay? This is why we do early prevention. If it doesn't kill you, it can lead to this kind of terribleness that we don't want. Okay. This is important also. Oh, I get this pain in my leg every time I do something. If I walk up a hill, I get this cramping, terrible pains in my leg. But funny, if I rest for 5 minutes, it's gone. Okay? May not be old age. Okay? The same process that is in the heart causing blockages in the heart causes blockages in the legs, causes blockages here in the carotid arteries. Okay? Here, it causes a heart attack. Here, it causes a stroke. Here, it causes what we call claudication or peripheral vascular disease, pain with walking. Anything that is atherosclerosis makes you worry about everything else. So if you have trouble here in your legs, I'm going to check your heart. Okay? If you have trouble here, I'm going to check your heart. A lot of people also think that if they're having a rapid heart rate, that means they're having a heart attack. And I can tell you that sometimes it's a sign that something's terribly wrong. So I don't tell people, oh, just don't worry about it if you think you're having a rapid heart rate. It needs to be dealt with. You need to come in and have us take a look at it. But by itself, it's not the heart rate that tells us that we're having trouble. Okay, and I'll talk about that too. This is one of my favorite cartoons. You're going to exercise an hour a day, you're going to be dead 24 hours a day. Which is more convenient for you? All right? So I can't tell you the importance of exercise. It is absolutely imperative. And so this happens to me a lot too. And I'll say this to my patients. I need you to exercise. 30 minutes a day, 5 to 7 days a week. More is better. And they'll look at me and say, I guess I'm going to have to start running. And I say, no. If you look like that would be so miserable to you that I know you'd never do it. So what I tell people about exercise is find something you like. Water aerobics is great. Walking at a fast pace, a pace that you can talk, but you'd rather not. Okay? That's the pace I want you to walk at when you walk. Some folks, and I see some of you guys out at the mall, walking through the mall when the weather's bad, that's wonderful. Riding a bike, something that you like. Polka dancing. I have one patient who polka dances 3 times a week. That's great exercise, and it's something that's pleasurable and you'll do. Okay, so this is all of us, right? Basically, the majority of people in the United States, heart disease is the leading cause of death. There are other groups that are a little bit more lucky, if you want to say that. This is second only to cancer. But the majority of us fall in here where heart disease is the leading cause of death. Okay? And here are your percentages. Okay? This is the map put out by the CDC on where people die from heart attacks. Okay? So this is quite remarkable. And coming from the South, I can tell you, this is my little spot right here where I came from, I can tell you, fried food, lack of exercise, diabetes numbers, if you took the diabetes map and slapped it on here, it'd look almost the same. Okay? All right. So probably if you're out there getting the humongo meal, you may already have some of these sides, so it might be a little redundant. Okay. Now let's talk a little bit about women, since there are a lot of women here in the audience. Notice anything that looks similar? Yeah, it's the same map, guys. I just want to really reiterate this. Women and men are basically the same here in prevalence, incidence, risk of death. Okay. Oh, and by the way, it's less up here, and some of us that live up here are kind of savvy. So yeah, it's less up here, but could that possibly be because there's less of us? Yeah. So, you look at some of the areas where there's more people, and it looks a little bit more kind of like over here. Okay. So for women, 1 in 4 females die of heart disease. Okay. What's interesting is that despite how much we know about this, and how many times I've said it today, only 54% of women know that. It's their #1 killer. So this is something a lot of times I go places, and unfortunately Susan kind of let the cat out of the bag before I started, but I often will start with the question is, when I'm speaking to women, who thinks, I'm going to give you 3 scenarios, breast cancer, stroke, heart attack. What's the leading cause of death? And I get a lot of folks that say breast cancer because they're out there and they're vocal and they're getting their message out. And that tells us as cardiologists that we need to be more vocal because everyone should know that it's heart disease. Okay. All right, so we talked about that already. This is just, again, facts. It's all of us. It's all of us. So no one gets out scot-free here. It's all of us. This is important too. Women may not have symptoms. So it's important that as women, we take our prevention very seriously, because not all of us have symptoms, and even those of us who do have symptoms, not always the same symptom. So, I mean, yes, that's definitely true. Yes, you have the classic clutching your chest and falling to the ground. That's real, but that's not the only thing that women experience, and we'll talk about that a little bit more too. So, risk factors. Cholesterol, blood pressure, smoking, diabetes, overweight, inactive. Okay, is any of these a surprise? I think I've probably said them 4 times so far. Okay, these are the things that we can change. I can't change whether you're old or young or a man or a woman, but I can tell you that it's kind of unlucky for guys. Men are more likely to have heart disease at a younger age, and it's really about 10 years younger. Women, we kind of do a little bit better, and there are lots of other reasons for that, but we tend to live a little longer before we have trouble. And I also can't help your family history. And that's important because sometimes that's your only risk factor, but it's still important enough that I have to know about it and that you need to be aware of it and pay attention to it yourself. All right, I'm going to talk about 2 cases. This is the first case, and I think these are going to really drive home what I see as patients. So I get a lot of people that come to my office and they say, Doc, I got to know what's going on and I got to know my risk. I had this, somebody came and gave this great talk about heart disease prevention, and now I want to know what my risk is. And I'm going to tell you this website. It's right there. Okay, anybody can do this. Okay, this is the website here. It's through the National Institutes of Health. Okay, so this is a 54-year-old woman who was chatting with her best friend, and she said, oh my gosh, my brother just had a heart attack. It was terrible. It was awful. I don't ever want to have to go through that. No one's loved one should have to go through that. So she comes in and says, Doc, tell me what my risk is and tell me where I sit. So we use something here called the Framingham Risk Tool. Framingham is this neat little community in upstate Massachusetts, if no one's ever been there. And they're very well known in the cardiac community because we have studied these people for generations, multiple generations. And we have so much information and data on these people that we have been able to say the population at large, these are your risks based on the people that have lived in Framingham for generations. And it really does bear out. So she's 54 years old. Her cholesterol, total cholesterol is 240. Good cholesterol is 38. She doesn't smoke, never smoked. Blood pressure, systolic blood pressure, the top number, the 142. As I told you, that fits in the high category just by 2 points. But she doesn't take any meds for blood pressure, so this is just where she lives. So we put her into this 10-year risk of having a heart attack score. So there's her age, she's a woman, her cholesterol, good cholesterol, non-smoker, blood pressure, and she's not on meds. Let's calculate her 10-year risk of having a heart attack. 3%, that's pretty good. That's pretty good. 3% chance of having a heart attack in 10 years. So that's what we would call a low-risk patient. Okay? Let's talk about case 2. Okay, young guy. 45-year-old guy. Okay? So here's what happened with this gentleman. You know, he's a young guy. He's got 2 small kids at home. And his wife thinks, you know, buddy, I'm worried about you. You know, you're kind of heavy. You don't really do a lot. I'm worried about you. I want you to be there to help raise our children. So she forces him to come in. Okay? So he's 45, cholesterol of 312 total. HDL is low at 21. He's a smoker. But he says, I only smoke a pack a day. All right? Okay. Systolic blood pressure is high at 150, and he takes meds. His wife got him to take some meds for blood pressure, but he's not taking them effectively, right, because his blood pressure is still high. So let's put him into our risk score. He's 45. He's a male. Cholesterol, good cholesterol. He's a smoker, and he's on meds for his high blood pressure. Greater than 30% risk of having a heart attack in 10 years. Okay? He's 45. Every year older that you are just increases your risk. And honestly, when you look at it, it doesn't look that bad, right? I mean, yeah, he's a smoker. His pressure's a little bit high. His cholesterol's high, but that's just cholesterol, right? I just want to impress upon you that even though this doesn't look that terrible on paper and he's a young guy, this is huge, greater than 30%. All right. So it's greater than 30 out of 100 people. Okay. So risk factors, in case you haven't caught these yet, high blood pressure, high cholesterol, and smoking are the biggest ones outside of diabetes, which is its own independent risk factor. Okay? That's a lot of Americans. Oh, half of the people in this country have at least one of these. So this is something we need to pay more attention to. Okay? Poor diet, not active, excessive alcohol use. And I want to talk about this because a lot of stuff has come out about drinking red wine. Okay? Let's all drink red wine. And here's what I'm going to say about this wine curve. Okay, what we have found is that wine, yes, red wine is helpful. A glass of red wine a day lowers your risk of cardiovascular disease, the old Mediterranean diet. Okay, that is true. But instead of it being like your risk is up here, you have a glass of wine, now your risk is here. You have 2 glasses of wine, your risk is here. 3 glasses of wine, you're here. 4 glasses of wine. Dude, 2 bottles of wine, you're never going to die. Okay? It doesn't work that way, okay? So what we found is for women, the break point is about 1 glass of wine, right? So 1 glass of wine, your risk goes down. 2 glasses of wine starts going up and up and up and up and up. Okay? For men, the break point is 2 glasses. So you have 1 glass of wine, 2 glasses of wine, and then it goes up. All right? So what we say as cardiologists is that we're never going to tell somebody who doesn't drink to start drinking. Okay? That's not going to be on my prescription pad. 1 bottle red wine. Q1 per week. But what I am going to say that is if you do drink, you need to moderate how much you drink. Okay? So a glass of red wine is great. Yay. Have a glass with dinner. Don't have 6. Okay?
Question.
Yes?
Will grape juice do the same?
I don't know okay, I'm sorry. The question was, does grape juice by itself do the same thing as the Mediterranean diet? And what I'm going to say is, I don't know. No one's looked at it. It's not nearly as sexy. So no one has studied it yet. It might. It might. I can't say it doesn't, but I think there's something to the fermentation. Because other studies have shown that beer, to a lesser degree, but hard alcohol as well, can show some benefit. But it's not as well studied, and I don't know that I would hang my hat on that research. So I don't know if it's the fermentation or something in the grapes. So reduce your risk, okay? This is where the rubber meets the road. Quit smoking. Quit smoking, quit smoking, quit smoking, quit smoking. Okay? As a cardiologist, I will do anything I can do in the world to help you quit smoking. It's the best and easiest thing, although it's not easy. It's the biggest risk reduction that you can achieve yourself. You can treat your diabetes, but you can't make it totally go away. You can stop this. Right? So if smoking, if you've never smoked, don't ever start. If you've started, quit. If you don't know how, talk to me afterwards. I'll help you. Okay? Blood pressure. Talk to your doctors when you have your blood pressure taken. If you go to the doctor and your blood pressure is up, what everyone says is, oh, I have white coat syndrome. Okay? When I go to the doctor, it scares me. My blood pressure goes up. Don't pay any attention to that blood pressure number. Right? When I'm at home, I'm sure it's better. Okay? So, and they may be right. But then when they come back and see you the second time and it's still high, you say, really? And that's at that point when you take it more seriously. And what I normally do is have someone come back in and check the blood pressure when I'm done, and I've shown them I'm such a nice, sweet person, and there's nothing to be afraid of, right? So then when they're relaxed, I check it again. But if you let 5 visits go by with high blood pressure, you as a patient or the physician is not doing the right thing. So as a patient, you need to be aware of that too and say, it's been pretty high the last 5 times I've been here. Maybe it's time to do something about it. Okay? Diabetes, your primary care doctor knows who's at risk and needs to test you for it. Okay? So if you have any kind of risk factors for diabetes, if you've had high sugars, if you have had an early heart attack or anything, you need to be tested for that. Talk to your primary care. Okay. Healthy food choices and being overweight. These are really important, and it's hard. In our society today, it's very difficult. If you live by yourself, it's very difficult unless you're going to cook for yourself every single night. Most things that come in a box are bad. Most things that come in a can are bad. And most things that are in the freezer are bad. Okay? These are things that are highly processed. And what processed foods do is they add sugar, fat, and salt because it's tasty. And you'll want to eat it more. And that's just the truth. Campbell's soup is so salty, it's just unbelievable how much sodium is in a can of soup. And I'm not singling out Campbell's, it's, most of them. At least nowadays they're having some low sodium options, but what I tell folks is your best food options are on the perimeter of the grocery store. Stay out of the middle. Okay? You've got your dairy case on one side, you've got your meats and seafoods on the back end, and then you've got produce on this end. Try to stay out of the middle if you can. Okay? And also stress definitely correlates with heart disease. And I know that sounds really easy. Oh, just live a less stressed life. But just keep it in your brain. Okay, the last little bit of time we have here, I'm going to talk about symptoms. And I want to just really make this clear. Because if I don't get to the end of the slides, that's not as important. This is the meat. Okay? Symptoms. Chest pain or chest discomfort. Okay? Either in the center of your chest, down low, sometimes radiating to the back, radiating to the left shoulder, left arm, left jaw. I've had people that said that the only symptom that they had was a toothache that was unrelenting. It would get better when they laid down, but when they got up and tried to do anything, that toothache was crazy. Okay? So that can definitely be a sign of heart disease, angina, or impending heart attack. Okay? Shortness of breath, that's unusual. Okay? We all get some shortness of breath, and I'll tell you, if I climb 5 flights of stairs, I'm going to be short of breath. But if I've climbed 5 stairs and I'm short of breath, that's a different story. So unusual for your typical amount of exertion. Lightheadedness, associated with nausea, vomiting, and sweating. Okay? This is a very important one. And I can't tell you, listen to your body, a sense of impending doom. And the number of times I've heard that, someone comes into the ER and says, I don't feel right, I can't tell what it is, but something's wrong. Okay? And they're right. They're usually right. So listen to your body. If you have indigestion that seems unusual, okay, think about something other than indigestion. Okay? If you've had a bottle of Tums and it hasn't helped, come to the ER. No one's ever going to get mad at you in the ER if you come and you're not having a heart attack. No one's ever going to get mad. Okay. So, okay, except maybe the insurance company, but that's out of my control. So this is what we talked about. Women are more likely to describe a different kind of chest pain. Neck, jaw, throat, between your shoulder blades. Okay.
Could it be the right side jaw?
Could it be the right side? Absolutely. And what I tell people is everybody's different, and I can't stand here and tell you what your heart symptoms are. Your heart pain's going to feel like this. Everyone is different. So you listen, and if it seems unnatural or weird, check it out. Okay? And again, sometimes folks don't have any symptoms at all until they have the big one. Okay? 40-year-old gentleman, super healthy guy, works out, cross-trains, CrossFit, whatever that is. That's all kinds of silliness. He was explaining it to me. I was like, I can't do that. So, he's way healthier than most people that I've ever met. Never had a symptom at all, but has had a family history of people having heart attacks in their 50s. He's 40, just turned 40, 3 little kids at home, four little kids at home. was working out at the gym and had a massive heart attack. And he thought I pulled a muscle. I was lifting that heavy, whatever, that round kettle-y thing that they do. I just must have pulled a muscle. But boy, it's getting hard to breathe. So then he was laying down on the treadmill trying to catch his breath with this pulled muscle that was getting really bad. And finally, one of his people that was training with him said, no, you need to get to the hospital, and he was having a massive heart attack. So if it seems unusual to you, that's what you need to think about, more so than just the typical stuff. Know the typical, but know you. Early. Call 911. Okay? Time is muscle. Time is heart muscle. I don't know how to say it any more than that. Call 911. Few people actually do it when you're standing there and you're faced with it. And you think, I'm just going to drive him to the emergency room. And I need to stress that. Don't drive someone to the emergency room, okay? Please call 911. It's life-saving. It's not a bill that's going to come to you later. It's the fact that the EMS can get there, do an EKG, know exactly what's going on, call the hospital. The hospital's waiting for you at the door, ready to get you to the cath lab to get that artery opened. Okay? So it's more to it than just ease and convenience. You know, even if you feel well enough to drive yourself, don't do it. Okay. All right. So let's see if I can say this in another way, the same 7 things, right? Okay. Please eat a healthy diet. Okay. Low salt, low fat, fruits and vegetables. Stay to the perimeter of the store. Once you get used to cooking with fresh fruits and vegetables, it's really hard to go back to stuff out of a box. And it's really less expensive if you do it consistently and you have a pantry that's full of fruits and vegetables. It's easier to cook with and it's less expensive. Exercise. Do something. 10-minute walk is great. Do something that you enjoy. Tennis. Anything like that. All right? Don't smoke.
Also don't chew.
Oh, right. That's very important. It's a very important point. It's not just smoking. Smoking is worse because the inhalation of those toxins actually is in the blood in the coronary arteries, causes direct harm to those blood vessels, the same way that glucose or high sugars have a direct toxic effect. The cigarette smoke itself does have a toxic effect. But you still are at risk if you chew or dip or smoke a pipe or all those other things. And the e-cigarette, I can't tell you that there's any data that it's better. I can't imagine why it would be better, except that you don't have the direct toxins. But I don't think that you're doing yourself a favor to start picking up the e-cigarette. Okay? If you're going to quit, quit. All right. Oh, and I'm sorry, and these are your cholesterol goals that we like, okay? We want your bad cholesterol less than 130, your good cholesterol high, 40, 50, okay? And your triglycerides less than 150. And these are what I worry about in diabetics and things like that. This is coming from like your pastas and your potatoes and stuff like that. Okay? Okay, let's see if I can say it one more time, okay? Lose weight, exercise, keep your sugars good. All right, and that's really what I have to say today. And I hope this was helpful, and I hope that it taught you some things that you knew already and reinforced, but hopefully I gave you at least 1 or 2 things that you didn't know.